Community health nursing differs whether the nurse is practicing in a rural type of setting versus a more urban setting. Differences in the community and the population groups make the nursing roles unique in whichever setting the nurse is practicing. Originally, care was provided by informal support systems. In 1912, the Red Cross Rural Nursing Book took a role and later shifted away from rural nursing. When we talk about rural, it is defined in terms of distance or time from an urban setting and density of population. The U.S. Census Bureau considers a community having less than 20,000 residents or less than 99 persons per square mile, about 25% of the population of the United States. When you compare rural to urban, you will see it on a continuum rather than being polar opposites. In a rural community, the population makeup is 82% white. The greater proportion of those are 6 to 17 years of age and over 65. So it basically tells you that they stay in that community for quite often, and usually they're made up of families. A greater number were or are married. A greater number of them are widowed, and that makes sense with the over 65 population. They have a lower education and lower socioeconomic status, and many of them have no insurance. When you talk about urban communities, the demographic makeup is 62% white, 40 to 43% 25 to 54 years, 19 to 26% of them are never married, 30 to 40% have greater than 12 years of education, and 6 to 22% live in poverty. So let's take some time to talk about health status of those in rural settings. Keep in mind, these are generalities found in the population. There are always exceptions. Perception is healthy. They engage in less physical activity during leisure time, don't wear seatbelts as much, smoke more, consume alcohol at a higher rate. Disease prevention and health promotion, they're less likely to have blood pressure checks, pap smears, and less self-care activities. As far as chronic illnesses go, more likely to have COPD, and that is because they have more smokers. Hypertension, heart disease, cardiovascular disease, and cancer. About one half have one of these diagnoses. AIDS, though, is more likely in urban areas. Physical limitations include mobility and self-care. 9% report 3 or more limitations. When talking about utilization patterns of healthcare, 3/4 make at least one visit to healthcare provider, but by number of visits per year, they score the lowest. Another impacting factor is the recurrent gas crisis, resulting in an increase in the number of services being curtailed based on gas prices and economic shortfalls. Meals on Wheels, home health aides, homemakers for programs such as Medicaid and Medicaid waiver. Rural dwellers are more likely to be able to name a regular care provider. Travel to ambulatory care averages about 30 minutes. 1 out of 17 rural counties are without a physician. Most rural care provided in a physician's office. Areas with a shortage of health care professionals are termed health professional shortage areas. With regards to maternal infant health morbidity, varies by county related to availability of health care areas, with infant mortality rate of 12.6 per thousand as compared to the national average of 10.4. Concentration of minority populations, where African American women in the Deep South and women near or on Indian reservations have poorer outcomes. Along with cultural beliefs related to pregnancy, one must consider environmental and occupational hazards that impact children. Case in point, migrant farm workers, babies born without appendages related to fertilizers, the use of fertilizers, etc. Children's health. Urban areas are less likely to have regular care provider, but more likely to have a pediatrician. Rural are more likely to have regular provider, but he or she is a general practitioner, usually cannot afford a school nurse but may work around that. In the mental health sector, there are fewer services, greater persistent endemic depression related to isolation and higher poverty, higher number of young male accidents and suicides. Historically, rural areas are hit hard by economic shifts, mining, logging, etc., and are ill-equipped to handle the needs of the whole town. Abuse is also harder to determine, as often the residents are related and closely acquainted, and therefore reporting is limited. With regards to minority health, Particular groups include Native Americans, Native Alaskans, Native Hawaiians, migrant workers, African American, and the homeless, who are often seasonal farm workers, or families who have lost their farms who have additional issues. Environmental and occupational health risks. OSHA lists high-risk occupations are noteworthy as being in rural areas: forestry, mining, fishing, and agriculture that contribute to health risks via machines and vehicular accidents, hair getting caught in a thresher, decapitation driving into the back of a coal truck or a log truck, trauma, certain cancers, respiratory diseases, birth defects from exposure to toxins, pesticides, or herbicides. These people, who often work in their own family businesses like the family farm, are not covered by workers' compensation or OSHA regulation. Some concepts related to nursing and rural nursing care environment. Rural dwellers do not perceive that they are far from care or isolated. With regards to nursing, there's lack of anonymity for the nurse, but also insider-outsider issues such as newcomer or old-timer mentally makes trust something that must be established. With regards to person, they perform informal caregivers they know, and they focus on independence. Research focus is needed in these areas. Nurse satisfaction in rural areas, including stresses and rewards, needs of rural client systems, especially for underrepresented groups in rural states east of the Mississippi, and also the international perspective. Okay, with regard to future perspectives, Healthy People 2020, the national health objectives, particular needs are evident when evaluating healthcare resources across the lifespan and care continuum for rural populations. Specifically, there is a need for school nurses, family planning services, prenatal care, care for individuals with AIDS, even though the number of the population is a lot less than urban areas, and their families, emergency care services, children with special needs, mental health services, and services for older adults such as adult daycare, homemakers, hospice, respite care, and meal deliveries. States have further developed guidelines that address the needs of rural populations within additional documents. Moving forward to help communities achieve Healthy People 2020 objectives means having accurate and meaningful statistics and measures of the community. All sectors of a community involve public, private, and volunteers. Getting the community to work together is a coordinated effort. The nurse cannot do this from outside, but only from within the community. In the rural community, the case manager may be a nurse or a social worker. The case manager works together with the client and possibly the client's family to arrange for the services needed, often to allow the client to remain at home rather than requiring more complex healthcare services such as a nursing home placement. Certain states participate in Medicaid waiver, which allows for a set number of hours of homemaker or other services in the home, so the person can continue to live at home rather than enter a nursing home. Community-oriented primary care, an ideal model for medically underserved communities, establishes a professional community partnership requiring a joint effort. This blends primary care services, public health, and prevention services to prevent overlap and maximize coverage. The multi-step process includes identifying the community's needs and willing partners such as volunteer health professionals. Next, healthcare services are either created or modified to meet the identified needs. Education and increasing awareness within the community is a large part of this process. And don't forget that evaluation is very important.